we're talking about today is subjects become near to my heart. What to do in Hinchy 1, Hinchy 2 diverticulitis. Basically, we're going to have two teams, one looking at continued non-operative intervention versus earlier operative intervention for patients who come in with 1, 2, 3 episodes of diverticulitis. Our two teams. First are sitting in the front row, Luke Couch and Victoria Miles will be championing the earlier operative team, which will be helped with Dr. Maxwell, and Kevin Harrell and Dresden Soderstrom, helped by Dr. Maxwell, advocating for earlier operative intervention. Both Stanley, sorry. Yes, Dr. Stanley will be on that team. Both teams have elected to go by coin flip on who goes first. I have a coin that Dr. Gates gave me, which apparently belongs to Dr. Arnold, so I'll be returning it to him at the end of the conference. And I dropped it. Where did it go? What is that?
And we're done. Give the man a coin.
All right, heads, you're in the front row. You go first.
Yeah, that was above 40.
That was bad.
All right, so today, like Greer said, we're discussing Hinchy 1 and 2 diverticulitis, to operate early or not to operate. We are the operate early team. We have no disclosures except that we are surgeons, and surgeons tend to operate. We know that diverticulitis is increasing in incidence, especially in young patients like this guy. We have the Hinchy classification that we're all very familiar with. So Hinchy 1 being colonic inflammation with pericolic abscess or phlegmon. Hinchy 2 being colonic inflammation with retroperitoneal or pelvic abscess, a more distant abscess. So in this study, they showed that of 99 patients managed non-operatively, 46, almost 50%, experienced a recurrent episode of diverticulitis requiring surgical resection. So we ask, why wait to operate? So to start with, I'm going to talk a little bit about what patients may benefit from an early operation rather than medical management. So here we looked at young patients, less than 40 years old, treated with early surgical resection. They found that 3 of their 20 patients, 15%, experienced recurrence of their symptoms, while 55%, 15 to 55%, patients treated medically did. So medically treated patients were found to have more ED visits, more pain, more readmissions, and became a much higher cost to the healthcare system as a whole. Again, now this was in DCR, Diseases of Colon and Rectum, fairly well-respected journal in colon and rectal surgery. 672 patients with diverticulitis analyzed over a 15-year period. They found that patients with a family history of diverticulitis, length of involved colon greater than 5 centimeters, retroperitoneal abscess, that they were more likely to have a higher risk of recurrence. They saw that patients with right-sided disease were at a lower risk, so maybe patients with these characteristics would benefit from an earlier intervention. And again, in DCR, they analyzed 210 patients with CT-documented diverticular abscess, which represents a complicated diverticulitis, as we all know, which was associated with a high risk of recurrence and disease complication. Recurrences after an abscess were often more severe than the index presentation, resulting in fistula, peritonitis, and stricture. They also found in this study that successful CT drainage did not appear to lower the risk of future recurrence or complication rates, and that CT-guided drainage did not change the overall outcome of the patient. Here in the World Journal of Gastroenterology, they looked at what patient characteristics in Hinchy 2 diverticulitis predicted failed medical management. So they did a logistic regression and found that abscesses greater than 6.75 centimeters with a white count greater than 14.8 and fever put the patient at a much higher risk to fail medical management. In this study, they found that the percutaneous drain failure rate, meaning the patient ended up needing surgery, that admission was up to 30%. They found that patients had a better prognosis if they had mesocolic or pericolic abscesses, and a much worse prognosis with pelvic abscesses, that sepsis was a lot more likely. Maybe those patients need an earlier operation. And maybe it's important to think about abscess location and size. And then here in the Journal of Gastrointestinal Surgery, they looked at repeated healthcare resource utilization in patients with diverticulitis. They looked at almost 43,000 patients with recurrent diverticulitis. They found that factors predicting recurrence were a younger age, as previously mentioned, a patient who's white, a patient who's obese, a patient with hypertension, pulmonary disease, hypothyroidism, rheumatoid arthritis, which likely is related to steroids, and depression. So they recommended to consider early operative intervention for diverticulitis in these patients. And then again, this team looked at, in Annals of Surgery, looked at hazard ratios to predict mortality of recurrence. So in patients who were 50 to 80, who smoked, who initially presented with complicated diverticulitis, and including abscess, fistula, obstruction, they recommended early surgical intervention to decrease their mortality. And then this is something we're all very, very familiar with. It's something that we discussed yesterday in conference. Patients who are immunocompromised, who are transplant patients, who are on chronic corticosteroid therapy, they showed a mortality increase for acute diverticulitis episode from 23% to 56% if they were treated medically. So obviously these patients would benefit from an earlier surgical intervention. And then Dr. Couch is going to talk a little bit about what operation we found for Henschel 1 and 2 diverticulitis would be most beneficial.
So if you're going to operate early, it begs the question, which operation should you perform? We looked at the literature. We've already kind of debated whether or not to primary anastomose somebody with diverticulitis. This is a systematic review from 2006 in the UK. It was also in DCR. It looked at 15 articles, 10 after 1990. The primary endpoint was mortality. Secondary endpoints were morbidity, operative time, and length of hospitalization. Included 963 patients. 57% of these received a primary anastomosis. 14% were diverted. The overall mortality was significantly decreased with a primary anastomosis versus a Hartmann's procedure. It leveled out and became more similar with Henschel 3 or 4, but it was much improved for Henschel 2. Therefore, this paper recommends definitely attempting to perform a primary anastomosis. This paper was a prospective trial also out of the UK. It was published as well in 2006. It looked at adult patients undergoing bowel resection or sigmoidectomy for complicated diverticulitis with a primary anastomosis or Hartmann's procedure, and excluded patients treated conservatively. The primary outcome was also 30-day mortality. It included 151 surgeons at 42 centers. 248 of these 539 patients received a primary resection with anastomosis. 28% were diverted, and 167 got a Hartmann's procedure. Once again, mortality was improved with a primary anastomosis, 4% versus almost 23.4%. The surgical complication rate was improved at 31% versus 53%, as well as the medical complication rate. So this paper was published in 2015 out of Milan. It looked at 219 patients, 180 of which were operative. 51% received a primary anastomosis. They demonstrated that these patients experienced decreased pain in ileus, earlier nasogastric tube removal, shorter length of stay, lower rate of major and minor complication, fewer operations, and overall lower mortality, and only 3% leaked with a primary anastomosis. This paper was out of St. Louis. It looked at 192 patients retrospectively. 67 of 73 patients underwent an operation with a primary anastomosis. 32% were diverted with an ileostomy, and 24% were diverted with a colostomy. They found that diverting with an ileostomy had a 4.5% mortality rate, and with a colostomy, 18%. No mortalities with the Hartman's procedure. And this, moving on to more current literature, this was an editorial from two colorectal surgeons at Mass General. They proposed that in an elective setting, a laparoscopic sigmoidectomy could be performed versus an open sigmoidectomy, and they advocated that it was a steeper learning curve, but way more beneficial for the patient, with less pain, better pulmonary function, cosmesis, shorter hospital stays, and fewer complications. And you can see that they demonstrate that with some of their own data here. Moving on, this was a study in Europe it was a randomized control trial. 52 patients either randomized to receive a laparoscopic sigmoid resection or an open sigmoid resection. You can see that the laparoscopic was associated with 15% reduction in major complication rates, less pain, improved quality of life, shorter hospitalization, and the only I guess downside is a longer operative time. But these patients leaked less, had fewer overall complications, and got out of the hospital sooner. This was a review article on current management from last year, and it demonstrated that in the hands of an experienced laparoscopist, emergency laparoscopic sigmoidectomy was safe, feasible, and proved to have significant advantage in terms of low conversion rate, need for re-intervention, morbidity, mortality, faster time to recovery, less ileus, decreased abdominal wall complications, and shorter time to oral intake. And in addition, these patients, if they were diverted, they had a higher rate of stomal reversal. The leak rates were equivalent. So who should you not operate on or early? It's the elderly with multiple medical comorbidities, especially if they're over 80. Delaying surgery and doing it more in an elective manner seems to benefit these patients. And then patients with Hinchey 1 diverticulitis are much less likely to recur than Hinchey 2, and these patients tend to do better treated medically.
As Dr. Burns mentioned last week in Grandrounds, I believe it's important to think about what the patients think too, especially in 2018 when this is becoming more to the forefront. So here we had data that was analyzed from 21 studies. This was published in the Clinical GI and Hepatology. They looked at about 2,000 diverticulitis patients, that's all comers with diverticulitis, undergoing laparoscopic surgical intervention for diverticulitis reported less GI symptoms, less chronic abdominal pain, and a better quality of life compared to medically managed patients. So in conclusion, as with almost all surgery, patient selection for early operative intervention for Hinchey 1 and 2 diverticulitis is absolutely key. We should consider early operative intervention in young patients who are more likely to experience a recurrence, and immunocompromised patients who are more likely to die, patients with a family history, patients with a length of involved colon greater than 5 centimeters, patients who are depressed, use tobacco, maybe patients who are white, patients who are obese, hypertension, have multiple medical comorbidities, patients with worsening of symptoms on antibiotics, that's fairly intuitive, and patients with abscess, especially retroperitoneal or pelvic abscesses, or fistula or obstruction on initial presentation. It seems to be safe to consider resection with primary anastomosis and avoiding multiple trips to the operating room. It seems that there's a limited role for laparoscopic lavage in Hinchey 1 and 2 diverticulitis when IR drain placement is available. That's why we didn't discuss it. It seems the bulk of the argument for laparoscopic lavage lies in Hinchey 3 diverticulitis. Not surprisingly, patients seem to have improved outcomes with laparoscopic resection in the hands of an experienced laparoscopist. You would consider a diverting loop ileostomy if you were concerned for ability to heal the anastomosis rather than a diverting loop colostomy. And as we mentioned, it seems that there's minimal role for an early surgical intervention for HE 1 diverticulitis. 2 is what really makes the difference. And then most of all, you may not want to believe Kevin Harrell, our lady surgeon who plays with tigers in the rain, drinks 4 glasses of wine in one sitting and tends to streak. Thanks.
Is this here for us to reference?
Yes. For the notes. Good morning. So Dr. Harrell and I represent the conservative management side of things, or as we like to call it, the common sense argument for common sense management. Just to address something that Dr. Miles pointed out, that surgeons like to operate. They say that you learn when to operate in your first 10 years and when not to operate in your second 10 years. So we would argue that it is the wise judgment of an elder surgeon that learns when not to operate on these patients. So again, let's look at Hinchey classification. We're talking about 1 and 2. We're not talking about 3 and 4. We're not talking about patients with peritonitis. We're talking about patients with localized abscesses, either pericolic or in the pelvis. And we want to touch on common sense again. So again, we're not talking about patients with peritonitis, even if they have this CT scan, which would represent a Hinchey 1 diverticulitis. We're not talking about patients that are unstable. We're not talking about patients that are worsening. And we're not talking about those special patient populations, such as patients that are immunocompromised. We're talking about all comers with acute Hinchey 1 and 2 diverticulitis. So when we first got assigned this debate, there was a lot of talk from the previous team, and I think we just saw evidence that they had a whole lot of articles supporting their claim. And they were going to spam us with a whole bunch of information. But we would like to present that we're going to give you quality over quantity. So this is a great article that looked at Hinchey 1 and 2 diverticulitis. And they said that the treatment of an uncomplicated disease, which they defined as Hinchey 1, typically consists of a trial of bowel arrest and intravenous or oral antibiotics. They also said that non-operative management with oral or IV antibiotics has shown to be successful in up to 90% of patients. So whoever said that's pretty smart. So if your name is, or if your face is on the screen, can you just raise your hand? Dr. Maxwell, are you with the other team or, or our team? I don't know that we need to say more, but we will. So this first article on the left here is current controversies in the management of diverticulitis. This is the article that Dr. Greer gave us when he kind of spurred this debate. And they go through a lot of points that we're going to address in this presentation. But essentially, they state that we have a movement towards increasingly conservative approach with respect to hospital admission, antibiotic treatment, and intervention. And there at the bottom, you can see an algorithm that they use for treating their patients, and we'll go over that at the end when we circle back. The second article here is from JAMA. It's out of Australia, and they looked at surgery for diverticulitis in the 21st century, and they made so many good points, 3 of which are listed here. So the reason this is a big debate is because the previous dogma was that after 2 bouts of diverticulitis, patients should be offered an elective resection, and now the literature is not really supporting that. So the severity of attacks has been shown to not increase. Instead, most patients' recurrent episodes will just mimic their earlier uncomplicated ones. They also looked at the likelihood of free perforation, which is always the scary thing. If you're going to manage these patients conservatively, there's a concern that they'll come back and they'll be worse. But the likelihood of that is far greater in patients with no history of diverticulitis than those that have recovered from 1 or even more episodes. And then they also looked at patients that underwent elective resection and how they fared postoperatively. And up to 20% of respondents in a postoperative survey reported no real long-term relief in their symptoms postoperatively, and up to 10% actually reported worse abdominal pain and gastrointestinal function. So this is Grandrounds, so we have to talk about the cost of medicine. This was a systematic review and meta-analysis of outpatient treatment for acute diverticulitis, and they looked at the safety and the cost savings of outpatient management of acute uncomplicated diverticulitis, which again included Hinchey 1 diverticulitis. And as you can see, they had a range of 42 to 82% savings in percentages. And I'm not really great at euros, but 1,600 euros is $1,850. So per patient, per visit, that's how much was saved by managing these patients outpatient. This is another article out of the Journal of Gastroenterology, and they looked at the management of diverticulitis in 2017 from a patient population at Mass Gen. They showed that elective colectomy after an initial episode of diverticulitis in young patients, which they defined as less than 50 years old, would have led to 13 unnecessary colectomies to prevent one colectomy with colostomy, and even more so in patients older than 50. And the American Society of Colon and Rectal Surgeons actually says that it's 18 unnecessary colectomies. And they concluded that given all of this data, patients should not be encouraged to undergo elective colectomy merely to avoid a more serious recurrence, as this more serious recurrence is very unlikely to recur. And in another way, patients that require emergency colectomy, again, that is usually their first episode of the disease, and these are not patients that are presenting with recurrent disease.
Thank you, Dr. Soderstrom. We're going to move on to talk about Hinchey 2 disease. Once again, going back to our local panel of experts, they continue in their fantastic review article describing Hinchey 2 patients and dividing them into smaller abscesses that are less than 3 centimeters, showing that they will improve with medical management alone, but maybe certain populations with larger abscesses may benefit from further conservative management, such as percutaneous drainage. And they showed that that would decrease the need for acute surgical intervention by 52 to 74%, which I think most patients would agree if there's a chance of avoiding a major surgery that they would want a trial of that. But the table below is a collection of papers included in the review article from our local panel of experts. And you can see low rates in the failed management of percutaneous drainage in these studies, which I think warrant at least a trial of non-operative management in these patient populations. I think you can trust the veracity of our slides as well, given the fact that we spelled Hinchey correctly throughout our entire presentation. But if you still don't believe our, if you still don't believe our local panel of experts, we'll give you some other groups of people that are giving similar recommendations. This is the guideline parameters from the American Society of Colon and Rectal Surgeons, a rather reputable organization. And we'll just read their bullet points. They write that urgent sigmoid colectomy is required for patients with diffuse peritonitis, again, common sense strategies, and for those whom non-operative management of acute diverticulitis fails. That to me indicates that you would start with the non-operative management and then proceed to operative management after that. And that's given strong recommendation based on high quality 1B evidence. And then another form of conservative management, which includes percutaneous drainage, they note that it's the appropriate treatment for stable patients with large diverticular abscesses, again with strong grade 1B evidence. And a quote that we found was that the practice of recommending elective colectomy to prevent a future recurrence requiring stoma formation is not supported and should be discouraged, which I think our opponents did point out in their presentation. A few more papers that we'd like to go over very briefly. This is another review article that looked at various quality of life metrics to evaluate the patients, how they kind of evaluated their own well-being after undergoing surgery versus conservative management. And they showed that patients with phlegmonous acute diverticulitis, they did not benefit from elective early sigmoid resection, and that they generally fared better after conservative management. And obviously, if they had surgery, they had more pain in the left lower quadrant, et cetera, which I know seems kind of obvious that if you cut someone open, they're going to have pain. But I think that does contribute greatly to quality of life, that if you can get someone over an episode just with conservative management, then they'll have those better outcomes. And then another review article that went through an exhaustive literature review. They were specifically looking at conservative treatment, but they were assessing evidence and quality of evidence for early surgical resection, and they found very little, noting that based on the scarce evidence, an initial conservative approach is advocated even for isolated pericolic extraluminal air. So that was specifically for perforated patients looking at the need for early surgery. And this was an excellent article out of Spain, and they looked at patients with, again, perforated acute diverticulitis with free air in the abdomen. They noted that it was safe and efficacious in selected patients, again, using their common sense strategies that we mentioned at the top of our talk. They had an 83% successful non-operative management. This was out of a total of 77 patients. And they had a recurrence of 20.4%, but that they had the same rate of risk of recurrence as any other patient presenting with a first episode. And again, 85.2% who were treated successfully, they did not require any further surgery, which I think is compelling evidence that you would, if it were me, I'd want a chance to not have to have my colon taken out, at least initially. And they did have some predictors of failure, which may go into, again, your common sense strategies to selecting patient populations such as ASA class and distant free air were their predictors of failure. This is an article from the Matt Much group out of the WashU and St. Louis group, who's a leader in the field of colon and rectal surgery. This is, again, looking at efficacy of non-operative management. And they are advocates for aggressive non-operative management, which we like that verbiage. And they note that it is safe and effective for patients with abscess or free air if they're hemodynamically stable. And so now we're going to begin to look at some of the published treatment algorithms that are used as guidelines for surgeons all over the world in assessing these patients. And you can see that obviously we're looking at stable patients here, and if they are grade 1 through 3, they strongly recommend a conservative approach to treating those patients. Next, this was a really interesting paper that looked at practice trends of surgeons, specifically in New York State, but they looked at over 250,000 patients. And the first graph just shows, as our opponents mentioned, that the rates of diverticulitis and the incidence is increasing over the last 2 decades. But the rates of surgery overall are actually decreasing. So the blue line here is the total rate of surgeries, and you can see that that's decreasing despite the increase in incidence. Now, there may be some slight upward trend in elective surgery, which I think in specific patient populations our opponents showed may be warranted, but then the levels of emergency surgery for those common sense solutions is staying relatively stable. But again, overall surgeries is decreasing. And then when you break that down by the top graph, I apologize, it's a little bit small. The top graph is by year. The next graph is broken down by gender. The third one is by race, and the last one is by insurance status. And you can see that most of these overall have a decreasing rate of surgery. And that's how these surgeons in New York are practicing, just to kind of give you an idea of a small subset of surgeons and how they are moving toward treating these patients. So we would say that if that's how, a big state and those surgeons are practicing, we don't want to get left behind, and you don't want to miss the bus on this, and you want to, I think we've shown some compelling evidence that conservative management is the right choice for these Hinchy 1 and 2 patients. Another published algorithm for treating these patients, again, just looking at Hinchy 1 and 2, all of the management recommendations are conservative therapy, and then right at the bottom, almost as a footnote, you might consider surgery in selected patients. And lastly, we circle back to the algorithm from the paper that Dr. Greer sort of birthed this debate from, and again, looking at if it's perforated, even you can look at Hinchy 1 and 2, and that always starts with a conservative management of oral antibiotics or a percutaneous drain, and if that fails, surgery might be indicated at that time. So again, just to kind of wrap everything up, our common sense solutions, we're going to start with medical management, but of course we're not going to be stubborn about it. We're not going to stick to our Hinchy, spelled with an I, classifications. You're going to, if you need to move to the operating room, then you do that in those particular patients.
So here are our conclusions. This is what we talked about today. So managing these patients conservatively is standard of care, according to the American Society of Colon and Rectal Surgeons. It's safe, it's effective. Recurrence and age of onset are not predictors for severity of disease and or future complications. We've talked about cost and how this is a more cost-effective approach, both for the patients and for the hospital system. And these patients have demonstrated improved quality of life in some studies. But if you don't want to listen to us, you can listen to your program director, part of our panel of experts who wrote that paper that stated that you can manage these patients non-operatively. You can listen to the director of the Critical Care Fellowship, Dr. Maxwell, who also thinks he's on the other side, but I think he's really on our side. You can listen to Dr. Stanley, who helped us with this presentation. You should listen to the American Society of Colon and Rectal Surgeons. And lastly, I really can't emphasize this enough, you should definitely listen to Dr. Zug. But don't listen to these guys. Okay. These are our references. We'd be happy to take any questions.
Yeah, thank you to both teams for compelling arguments. I've been asked to take the pictures off. This time I want to ask our faculty members from each team to go over maybe a rebuttal and some of their thoughts. Since the operative team went first, we'll let Dr. Maxwell start.
Okay, thanks. Clearly, you all found a typesetter error in that typo in that one manuscript. I think the conservative team did a pretty good job of driving their point home and into the dirt. But the thing about the literature on diverticulitis is there is so much out there that you can take the literature and make just about any argument you want on any point. The thing to be cautious about with the literature is most of the studies, there's a lot of prospective studies, but it's surgeon determined what operation they're going to do or whether or not they're going to operate. And there's very few randomized trials, and you can do all the logistic regression analysis that you want to try and make these groups equal, but I don't think they're ever really equal unless they're randomized. And I think there was just like 1 or 2 papers that were truly randomized studies. So you can't really put a lot of weight on that as being the ultimate determination when you don't have randomized data. So I think, it's all about patient selection. I think the points made about large abscesses and long segments of diverticulitis are important. That I think those factors truly lead to increased incidences of recurrence, which is what we want to try and prevent. And looking at those patients in the immunocompromised patient are all at risk for failure. The other point is that what I think most of the faculty on the acute care surgery service try to do is take one of these complicated diverticulitis patients and get them over their initial episode or that episode and get them to an elective setting with a bowel prep and hopefully a laparoscopic approach if they're amenable to that. But it's all about patient selection, getting the right patient. When you get them over their initial bout, you got to do the risk-benefit assessment and whether or not they're a good candidate. I think if you have complicated diverticulitis, one of the take-home messages from the literature that we tried to highlight in that review article was that your incidence of recurrence is about 30% at a year. So you got to take that factor and discuss that with the patient and what their goals are and try and do a risk stratification and see if an elective operation is beneficial for them.
Yeah, I really agree with what Dr. Maxwell was saying, especially about the papers. In fact, if you look at the ones, and I think both teams did a really good job of bringing some very salient points before us here, is you can see patient selection, you can see selection bias, you can see mainly they're descriptive, they may be retrospective and comparative with different cohorts, but I agree that, and that's why I think it's taken so long for the society to sort of develop their recommendations, because if you look 15 years ago, it was clear, after 2 episodes you'd operate, and they have really moderated that quite a bit. So that now I agree, when you get somebody in, you have to individualize, and a lot of the things you brought up there are things that we think about, especially the patient who's immunocompromised, that has Hinchey 1 or 2. Those are probably the common sense ones that we need to operate on, right away, and not wait for them to have a worse complication. Another couple points. One of them is they mentioned free air, and I got to visit that pretty acutely last year on a patient. And there's some good data now that really you just treat people clinically, even if there's distant free air. And there are some people that stratify it based on the CT appearance of that to try to figure out who would have a higher or lower risk for need for operative intervention. But I think in pretty much all these cases, you need to address people clinically. As far as laparoscopy, I've started doing even acute patients laparoscopically with resections and anastomosis. But again, I agree with Dr. Maxwell. You're going to do better if you can get them over it if they're doing well. But the person that's not getting better, the person that has smoldering diverticulitis, regardless of the Hinchey grade, those people need operations. So anyway, I think y'all did a fantastic job.
One other point about the free air thing.
Bob?
The free air thing, we watch a lot of free air, but I think if they got free air and free fluid, that's a higher risk for failure. That means they're probably leaking more than just air, and that patient's not going to do as well.
Any other questions or comments? Yes, Dr. Smith?
Thank you. That was actually quite enjoyable. The presentations were interesting. The thing I took away from this was that you can operate acutely and do a primary anastomosis. That's safe. All the stuff that you've shown was mainly retrospective, and the patients who got a Hartman's had probably worse disease when you went in, and the surgeon didn't feel safe hooking them up. This goes back to the common sense, the art of medicine, the thing that we continue to fall back upon. But the old teaching of you've got to give them a colostomy if you operate acutely, I think has been mostly debunked by this, that you can do a primary anastomosis, which a lot of people in the past were less likely to do given acute infection. So if I've taken anything away from this, that yes, you can operate early, given the patient's parameters. If you do, primary anastomosis is acceptable. The other thing I would ask is that the non-operative patients, we went into none of the diet modification, none of the lifestyle modification that truly has a lot to do with the decreased recurrence of diverticulitis. But of course, you're in a retrospective study, you don't have time to present the whole paper. And I would caution you to compare European medicine to our medicine. While they have some good data, I think they're much more driven on a socialistic payer system than we are, and what they're allowed to do versus what we do professionally. So just take that away from European stuff.
Yeah, Dr. Greer?
I just had a question that, having done this years ago, when you're doing the acute patients, are you lavaging the colon on the table before you do the anastomosis? I'm just curious, because I've done that before in a 400-pounder with a perforated colon once, and it worked, but man, it was tough. But do y'all irrigate proximal or distal or anything like that when you're doing a primary unprepped bowel?
I haven't. The stool in the colon makes me cringe, but the whole on-table lavage is just a messy proposition, particularly at 2 o'clock.
Yeah, I agree. I've kind of gotten away from that. I've done it a number of times. But I think if I'm, sometimes what I'll do just in the operating room, if I'm going to do that, and especially if they're open, is you can actually try to empty the colon just by sort of, milking it into the specimen, and a fairly low the burden of stool, and then you diverting loop ileostomy. I think you can diminish. And especially what changed my mind was when we started doing more colectomies, probably 10 years ago, without any prep at all. And, that sort of pendulum has swung, but the fact that it swung so much made me wonder if we were getting that much benefit from going through all the gymnastics of trying to clean it out and the potential contamination that occurs with that.
You do antibiotic irrigation?
I don't. Yeah, I never did an antibiotic when in irrigation we did that.
The other thing that I've done a couple of times now is these people that present, and they need to have an operation for whatever reason you've decided that they need to have a resection. If they still have flatulence and are having bowel movements, I'll bowel prep them before I take them for an acute intervention for acute diverticulitis, I think. Miralax. Just give them Miralax. It makes me nervous, and I personally go by and lay my hand on their abdomen a couple of times while they're doing that to make sure they're not blowing their perforation out. But I've bowel prepped several people, and I think that really helps. I'm way into the bowel prep club.
I have not done this in years either, but have we learned any more about prevention, etiology, early diagnosis? Phil Smith mentioned lifestyle modification, but it goes beyond that. I mean, I don't think in the last 40 years we learned anything new about, this is the same debate we had 40 years ago. And Dr. Burns can attest to that when we used to do this ourselves. And but have we learned in your reading any more about why this happens? I mean, I know all kind of theories about it, or how can we screen young population for these things?
Yeah, Dr. Stanley?
Yeah, so sort of the theories, everybody probably knows the sort of the theory of this the small caliber stool or colon with increased pressures and the physiology of that. But there's also the second one is an autoimmune theory, and that has to go with diverticulosis associated colitis. And in fact, there are a number of studies where they're using 5-ASA compounds to see whether or not you could have prevention using those. They didn't really pan out very well, but I think also Dr. Maxwell and one of their teams mentioned the long segments. And there are some people who will have these long segments, and if you look at them, they look pathologically different than some of the others. And I think there is probably some of this secondary causes that we haven't really worked out very well, but I think that's another reason why the long segments tend to recur. And they also tend to be the ones that people have had for a long time and are smoldering.
Nelson, you're a vegetarian. What about diet? Show us
Got to
something.
say something about fiber, of course. Yeah, I agree with what Dr. Stanley said. It seems to me that there's actually different types of diverticulitis, and certainly the old theory about segmentation and the increased pressure in those segments was pretty well proven by manometric studies, but I don't think that's the whole story. That may explain the lack of diverticulitis in Africa or something. There's undoubtedly genetic factors as well, and these segments of smoldering diverticulitis I don't think are related actually to the fiber intake. I think it's actually on the spectrum of inflammatory bowel disease. And it may be in the future, once we understand the gut microbiome better and the genetics behind it better, that this debate will be an entirely different one based on those other factors. And we'll manage some medically and we'll manage some surgically.
So you guys hurry up so I can see that coming at my age, okay?
Dr. Maxwell?
The diet thing got mentioned, and since we have medical students here, I'd just take the opportunity to make one more comment that as far as diet and seed type foods, there's not one shred of scientific evidence that shows that eating tomatoes or okra or sesame seeds or anything like that increases your risk of diverticulitis. Eating a high fiber diet in general, which a lot of the seed containing foods have a lot of fiber in them, has shown some benefit to reducing the risk of recurrent diverticulitis.
That's an interesting point. I can remember all the way back to medical school. The one thing everybody could remember, if you had a patient with diverticulitis, you always told them not to eat peanuts. I mean, you know, and that hung on for years, you know, and I'm sure there's still.
I would say at least half of the lay public has been told by somebody that they shouldn't eat seeds.
Yeah, sure. Yeah.
Completely wrong.
There's actually a study where they used
Here, Don. Here. Sorry.
There's a study where they were looking at popcorn consumption, and actually the people that ate more popcorn had less diverticulitis.
Yeah, that was the other one, yeah. Okay, that's it. That's a good one. Do our reviewers have any other comments about this or any of the questions that have been raised? I think there are several things to notice, and again, particularly with reference to the students, because haven't met with you guys to know what your long-term interests are, but there were several things that they brought up that were particularly interesting for just us as doctors, first of all, and that is the incidence of diverticulitis, for whatever reason, is going up. And you know, I don't know that the dietary intake, for example, has changed very much over time. So your points about the microbiome and the genome, you know, maybe there's a lot of potential opportunity for somebody to identify what does make this different. And again, as was pointed out several times, grossly, if you go back to gross pathology, there is a difference in patients with the long segments versus the short segments. I was always amazed at that, but never really heard people mention it very much. But it definitely is that way. You want to comment on that?
Yeah, one more thing about the age issue, and it may be related a little bit also to colon cancer in young folks. And one of the recent theories they have on that is that with obesity, there's also increasing mediators of inflammation naturally in patients that are obese, and that's one of the risk factors here for recurrence also is obesity, if you saw one of those slides. So, and when I think about the young people I've operated on, generally it's the obese male. And so I think that there's some things with that have to do with inflammation and immune system that may be explaining both of those.
The reality is we don't know.
Yeah.
We can't throw in theories out there of what's fashionable.
But I think when you get back to the issue though about raising the issue about obesity, that also tilts you in the direction of primary anastomosis too, because ostomies in this day and age with the thickness of abdominal wall is a huge technical problem for a surgeon. And so at least for me, years ago, I started pushing me in that direction just because I said, I don't think I can make this ostomy ever work. And so it's not, maybe that's a secondary reason to do primary, but it sure is one that's real. You want to comment?
One more comment, sorry. The risk of colon cancers up to 10% in some of these series. So somebody that has diverticulitis that hasn't had a colonoscopy in the past 3 to 5 years, they probably need to have a colonoscopy once they're 6 weeks over their event to make sure it's not an underlying malignancy.
Beautiful point. Beautiful point, because the most miserable patient I think I ever saw was a guy who was treated in the 60s with just drainage, open drainage and proximal diversion, but really had cancer in addition to diverticular disease. And by the time anything got done, had extensive local disease, and it was horrible. So that's a real important point to make.
Yeah, that's a real good point too, because as most people in here know, but you all may not, it's a different operation for diverticulitis that is benign versus a cancer. So then if you're going to go in urgently or emergently, what I found is that usually I can get them asleep, clamp it proximally, and then just put a scope, even if it's a gastroscope, a small caliber scope, you can get a real good idea whether there's a cancer or not, and then you can adjust your surgery. And sometimes it's important not to have to get the whole mesentery because there's inflammation down by the ureters and everything else. You can make it a safer operation if you know what operation you need to do.
Okay, a few more general points. Again, students, and especially surgery residents. Don't ever miss the opportunity to lay your hands on a patient that somebody said, I believe they have peritonitis. Because that's something, just like Michael Jordan shooting foul shots, you're only going to get really good at it if you do a lot of it. Nobody innately knows this is peritonitis or this is not, and yet this is a disease process that, as you've heard them say, nobody argues with the fact that with peritonitis you ought to at least be considering surgery. Now, you might not decide to do it, but you need to sure know, how did peritonitis feel this morning as compared to how it felt just now this afternoon. And so if you're going to treat these patients conservatively, the other thing you have to do is make time in your day to see that patient multiple times yourself, because it's a sequential observation of what your fingers and your synapses tell you about what this feels like and what that patient looks like. And I think that's really an important point for everybody to make, and especially if you're going into primary care, you're going to have these people and you're going to need to make that decision. This patient has peritonitis, they need to see a surgeon and me maybe, but they need to get on with it, because that timing early in some of these patients, and especially those that are at risk, as you pointed out, for immune suppression, transplantation, et cetera, those are really important. You have another comment?
Just one point about the students. Anytime you have an abnormal finding on an abdominal examination, grab a student, grab all of them, let them go see the patient. Yeah. Don't let that go by. Even if they're not on your service, just find one of them. You can find them and get them to go check that patient.
You hear of anybody who says that I've got a patient with peritonitis, won't take you but a minute. Apologize to the patient if you have to, but feel what that feels like. Because there are all different gradations of clinical evaluation about what peritonitis looks like. I think to also point out that the conservative treatment is good, but remember that there was a whole list that both teams had of the outliers that you have to be more aggressive with. Now, being more aggressive may not mean you necessarily operate, but you are more aggressive about how frequently you look at them and how you evaluate how they are, because they can get pretty sick pretty quick. I found in particular in my practice the arthritis here. Once we got a rheumatologist here in Chattanooga, we ended up with a whole lot more patients treated with diverticulitis because they were identifying these patients earlier, and that was a special risk factor for me, and I can't help but believe it isn't the anti-inflammatory drugs that a lot of them were on for a long period of time. But anyway, this was an excellent presentation by all you guys. Very well done. Thanks to the faculty for your support and all that. Good job, guys. Thank you.